Good morning. The Subcommittee on Health of the Senate Finance Committee will come to order. I first want to thank Senator Wyden and Senator Crapo for their help in allowing us to move forward with this hearing today in regards to transplants. I also want to acknowledge Senator Young, not only for his taking on the responsibilities for this hearing, but also his leadership on this issue. And we thank Senator Daines for his cooperation in allowing the subcommittee to proceed with today's hearing. And lastly, I want to thank Senator Grassley, who has been the real champion on this issue for many, many years. He will be joining us. He's at the Judiciary Committee right now, and he will be joining us shortly, and at that time he will be recognized for his opening statements. In the United States, the need for organs is far greater than those available. There are about 104,000 adults and children on the national transplant wait list, and every 10 minutes another person is added to it. In 2020, the Senate Committee on Finance did an investigation into the system and documented significant failures. Today, we discuss the path forward to a better system. My constituents in Maryland have access to 2 excellent transplant centers in our state. Maryland also has a Tier 1 organ procurement organization, OPO, that is taking innovative action in some of the most underserved areas like Baltimore City to encourage organ donation. This OPO has been among the top 10 performers nationwide. Access to transplant in Maryland is far from perfect. Despite the high-performance transplant ecosystem, due to the major underlying issues with the current transplant network, 148 people died while on transplant waiting lists in Maryland last year. That's unacceptable. Other states are not so lucky. Marylanders and people across the nation deserve better. Nationally, 17 people die each day waiting for an organ transplant. OPOs are ranked Tier 1, Tier 2, Tier 3, depending on performance levels, Tier 3 being the lowest. According to the Center for Medicare and Medicaid Services in 2023 performance review, 24 OPOs, or 42%, have been classified in Tier 3. Senator Wyden, Grassley, and Young and I have been leading the Senate Finance Committee's investigation into the organ transplant system for over 3 years. And each new line of inquiry has exposed more and more failures, which are often borne by the sickest patients in the nation. Specifically, our committee has uncovered transportation and testing failures that have put patients' lives at risk, outdated information technology underlining the network, a lack of oversight by the current Organ Procurement and Transplantation Network, OPTN, contractors, the United Network of Organ Sharing, UNOS, and misuse of Medicare funds. These disparities impact people throughout the country, including those who are low income, the uninsured, members of racial and ethnic minorities, people with disabilities, and rural populations. Even more concerning, the U.S. Digital Service has found that UNOS is incapable of modernizing the OPTN IT infrastructure. The stakes of neglecting the needs of the underserved community could not be higher. During the last administration, CMS put out an OPO final rule which will establish a performance tiering system that triggers decertification, competition, and potential DSA reassignment. HRSA has taken critical steps to modernize the OPTN, but statutory changes are necessary to ensure that HRSA is able to work with the better-equipped organizations to ensure the OPTNs is operating in an efficient and safe manner. When lives are at stake, Congress cannot accept logistics or poor administration as excuses. Last week, we held a roundtable with senior officials from the Center of Medicare and Medicaid Services and HRSA. It was a productive conversation where we discussed efforts to modernize the organ transplant system and increase transparency and accountability. Currently, we have a system that works well for some, as some of our witnesses will discuss today, but that is insufficient. Where an individual lives or their ability to afford travel to get care should not determine access to life-saving organs. Today, we have the opportunity to hear from patients and professionals who are working on key reforms. Our committee will continue to address the biggest challenges facing our nation, including the transplant system. We demand better and will not stop until we make it so. With that, let me recognize Senator Young.
Thank you, Chairman Cardin, for your leadership on this issue. I see Senator Wyden here, who's shown exemplary leadership as it relates to this issue as well. Senator Grassley, one of the real champions, as indicated, will be joining us a bit later, as I understand. Every day, 17 people die while on organ transplant waiting lists, and another 13 are removed from the waiting list because they become too sick to receive a transplant. In total, there are more than 100,000 Americans on the organ transplant waiting list today, including nearly 1,200 in my home state of Indiana. These aren't just statistics. These are lives. Organ donation's a personal issue for me. My friend, Dave Gunny McFarland from Jeffersonville, Indiana, died because his heart transplant never came. We served together in the United States Marine Corps, and I've gotten to know Gunny's wife, Jennifer, over the years. She's made it her mission to raise awareness about the transplant process and to help prevent others from facing a similar fate. Because the organ transplant system is so complex, most people don't know how it works or if patients are being protected. Now, I began looking into this issue right after being elected to the House of Representatives in 2010. In the early 2010s, I explored ways to try and incentivize some innovation in this space. I had a silly idea to try and create a prize concept to coax people into innovating in the kidney space. The bureaucrats told me it will go nowhere. I began working on organ procurement, oversight, and reform in 2018. I told the Washington Post then, we can't continue to allow thousands of Americans to die each year waiting for life-saving organs that we know are available if only this system were being managed by competent individuals operating in the light of day. I was proud to help champion performance measures for organ procurement organizations, which the Centers for Medicare and Medicaid Services adopted and finalized in 2020, and to join my colleagues, Chairman Wyden, former Chairman Grassley, and Senator Cardin, in launching an investigation that same year. I welcome the announcement earlier this year that HRSA will break up the organ procurement and transplantation network monopoly. And I join my colleagues to co-lead the Securing the U.S. Organ Procurement and Transplantation Network Act, bipartisan legislation that gives HRSA the tools to implement common sense reforms to act in patients' interests. But there's still much work to be done, and our friends and neighbors are still dying every day. It doesn't have to be this way. A functional organ donation system could facilitate tens of thousands more organ transplants every year. Americans deserve to know what the organ donation and transplantation system and their government is doing to increase organ donation and transplantation, as well as to ensure patient safety. HHS and Congress must treat organ donation reform with the urgency it deserves. Lives are being lost, and we can't stand by while some of our most vulnerable neighbors die on the organ waiting list, waiting for a call that never comes. We need strict enforcement of the OPO rule, reform of the OPTN, and to ensure the entire organ donation and transplant system operates in the best interest of patients. We've taken initial steps, but cannot stop there. I look forward to hearing from our witnesses and learning from their experiences and expertise of living and working within the organ donation and transplant system on a daily basis. I won't stop working on this issue until we increase the availability of organs for patients in need and eliminate the inefficiencies occurring in our organ donation system. Thank you.
Thank you, Senator Young. The Senate Finance Committee, under the leadership of Senator Wyden, has been the moving factor in the investigations done that uncovered so many of the mistakes and abuses that we have in the current system. Senator Wyden has been our leader and captain on this issue. Senator Wyden.
Thank you, Chairman Cardin. And I just want to note that one aspect of our service on the Finance Committee is we have always considered this committee where you see the NBA All-Stars in the healthcare arena. And certainly, Chairman Cardin has been continuing that. I'm sitting in the seat this morning that was occupied for many years by Senator Rockefeller, who was a great champion and would be with us all the way in terms of cleaning up these abuses that my colleagues have just mentioned. And then I also especially want to thank our Republican colleagues, Senator Grassley and Senator Young. This has been in the best tradition of the Senate Finance Committee, with all these all-stars we have in healthcare policy, to work in a bipartisan way, and I appreciate it. I'm going to be very brief. We've got a terrific panel of witnesses, and I'm going to have to be in and out. To just start by updating members and the public about our work, and particularly moving forward with the Health Resources and Services Administration to implement their modernization of OPTN, the Oregon Procurement Network. We're pleased with the bipartisan support that the bill's gotten, and it's been good to see that UNOS is not opposing the legislation. I can report to my colleagues and people who are following this, I've had a number of productive conversations with Chairman Sanders on this, and I want everybody to understand, because I'm not going to be able to be here for the whole discussion, this committee, on a bipartisan basis, as witnessed by my colleagues here, we are going to be pulling out all the stops to get the Senate to act on this issue as soon as possible. And the reason we are is because both of my colleagues just mentioned it. I think Senator Young used the word urgency. Can't sum it up better than that, other than maybe a capital U, because this is a matter of life and death for too many Americans. There is not a moment to lose, friends, with respect to getting this bill passed. And HRSA, the Health Resources Agency, is on track to begin the contract process this fall, and we're just going to be working here to complement their effort. Now, last week we hosted a meeting with officials from HRSA and the Centers for Medicare and Medicaid Services to discuss the administration's efforts to modernize the network, connect more Americans with life-saving organs, and particularly bring more accountability and competition to the contracting process. And the three of us, and Senator Grassley and others who attended, we got the message loud and clear that the agencies want to show a new emphasis on accountability and coordination. And that was very welcome. A couple of other points, and that is this hearing is going to give us another chance to clear up some of the confusion about what the legislation sets out to do and the rumors. And if you listen, to the rumors, I'm telling you, they are trying to basically run a kind of incumbent protection program and smear this bill. And Senator Grassley and I, in particular, at this session, asked questions with respect to our legislation and these so-called rumors that the three of us are going to want to privatize, the system. I mean, if you listen to these rumors, it would be like Congress people are trying to sell organs on the side. It was outrageous, the kind of stuff that we were hearing. And here's what we were told by HRSA, the Health Resources Agency, quote, "No, the system is not being privatized, period. In fact, HRSA notes that our bill will, for the first time, mandate an independent board of directors to oversee OPTN separate from the contract holder." Second, I asked HRSA to explain the boundaries that are actually in place for a nonprofit organization. How's it going to work if they get a contract as part of OPTN? They said that for-profit organizations would be held to strict federal standards for contractors. And let me quote again, "Limits on profits and fees and comprehensive oversight both before and after the contract award," unquote. HRSA also made clear they intend for the section of the contract concerning support for the independent OPTN board of directors to be awarded to a nonprofit, organization. So to all those people that are trying to spread these false and ugly, rumors about what this bill does, shame on you. And we're going to blow the whistle and make sure that the American people know the facts. These colleagues will be here this morning. I'll be in and out. We're working in a bipartisan way. And by the way, special credit to Senator Grassley, who with me is the co-chair of the Whistleblowers Caucus. We know a little bit about people speaking out if there are abuses. That is not the case here. So I'll just wrap up by saying here's what's on offer. We want to make sure that our country has the best in-class organ transplantation system in the world. And we found critical failures, looking in a bipartisan way from the current contract holder, especially when it comes to matters such as information technology and logistics. So the bill was written from top to bottom to ensure competition for technical functions like those that will help the OPTN perform to the highest level possible. Thanks to my colleagues, and I've spoken to both of them in recent days, and everybody understand this is priority business for the Senate Finance Committee, and there isn't going to be an ounce of partisanship here. We're going to stay at it till we get this done because the American people deserve it. It is long overdue. Senator Grassley, before you came, and I don't want to make this a bouquet tossing contest, I was talking about the fact that you've been bulldogging this every step of the way, and I really was grateful last week when we had the session to go through the legislation that we could all be together, and we appreciated your words blowing the whistle on these outrageous rumors that have been spread by some people who don't really want, change, that somehow this would privatize things. So thanks for all your good work, and you'll see it on the record that we are just so appreciative of your leading this for so many years.
Can I respond by saying that I owe you a big thank you, because as we were finishing some of the stuff I started a long time ago, you were there helping me with every letter and every move we made on it. So
we're in it together for the public. Thank you, Mr. Chairman.
Well, thank you, Senator Wyden, and thank you for your commitment to keep this on track to get done. It is very, very bipartisan. Senator Young and I have already commented about Senator Grassley's leadership on this issue. We have both been mentored by Senator Grassley in regards to the need for this committee's oversight on programs that we enact, and he has taught us well. Senator Grassley, thank you for your leadership on this issue. You're recognized.
Okay. Well, thank you, Chairman Cardin. Today, we're here to visit about the urgent need to reform the transplant system and the deadly cost to patients and generous donor families due to decades of inaction. In 2005, I started the investigation of the deadly failures of UNOS and the monopoly tasked with managing the U.S. organ donation system. Since then, more than 200,000 patients have needlessly died on the organ waiting list. There's a reason that I call UNOS the fox guarding the henhouse. For nearly 2 decades, UNOS has concealed serious problems at the nation's organ procurement organization, known as OPOs, instead of working to uncover and correct the corruption. This human tragedy is even more horrific because many of these deaths were preventable. They were the result of corrupt, unaccountable monopoly that operates more like a cartel than a public servant. Our bipartisan investigation, which started when I was chairman of the committee, and I already referred to Chairman Wyden's efforts in this, working with me. We uncovered kidneys lost in airports, technology systems that regularly go down, and the cover-up of patients' death. It uncovered a history of misinformation and lobbying against accountability and transparency for the local OPOs it's supposed to oversee. We are also aware of ongoing threats to whistleblowers and patient advocates. Instead of amending its bylaws to protect these brave individuals, UNOS has continued its longstanding practice of intimidation and retaliation. This is unacceptable. Tens of thousands of organs go to waste every year, exploiting generous donor families while organ procurement executives travel on luxury private jets to five-star resorts. Investigative reporting has revealed anti-competitive behavior designed to block new entities from competitive bidding process for new contracts. Entities that have the technology and skill desperately needed to save our lives. Our nation's organ procurement system is a deadly failure. In recent years, UNIS has attempted to disguise its failures by misrepresenting alleged record increases in organ donations. Unfortunately, these increases are the results of public health tragedies, including opioid epidemic, which has ravaged our rural communities. It's time that we put an end to UNIS attempts to use the nation's drug crisis to juice up its members to try and show the system is working. Simply put, the system is not working. For too long, UNIS has run a system that benefits the executives who run it, collecting taxpayers' funded perks and paychecks. It's been more than 20 years since Forbes called UNIS, quote, the federal monopoly that's chilling the supply of transplantable organs and letting Americans who need them die needlessly, end of Forbes quote. Our bipartisan investigation was clear. UNIS failed our fellow Americans, and disproportionately so with respect to to people of color and rural residents. The solution is also clear. Congress must pass our bipartisan bill 1668. Patient lives are at stake. I yield. Thank you, Mr. Chairman.
Senator Grassley, thank you for your statement. More importantly, thank you for your leadership. And in response to Senator Wyden, our topic, I think, very much underscores the point that you made, the cost of inaction and the urgent need to reform the U.S. transplant system. We have an excellent panel that have experienced firsthand the challenges in our transplantation system. So we're very pleased to have all of our witnesses here today to help us in this regard. Your entire statements will be made part of our record, and you'll be permitted to proceed as you wish. I'm going to introduce the five of you in the order in which you will be speaking. I'll start with Ms. LaQuaja Goldring, who is from Barnstown, Kentucky, is a pre-medical graduate from the University of Louisville. She is a previous kidney transplant recipient and current kidney transplant candidate. She received the Lisa Allgood Excellence in Kidney Disease Education Award from the National Kidney Foundation, awarded to those focused on improving the care and outcome for those affected, as well as communicating risk factors and implementing outreach efforts. Her first publication appeared in the Stat News, highlighting the failures of our U.S. organ donation system in Black and brown individuals seeking transplants. She'll be followed by Mrs. Molly McCarthy, a three-time kidney transplant recipient. She grew up in Northwest Illinois and received her first transplant in 1991 at the University of Iowa, her second at the University of Wisconsin, and her third at the University of Washington. She is in her fifth year as a volunteer with the OPTM Patient Affairs Committee, serving for the last 3 years as vice chair of the committee. Our third witness is Mr. Matthew Wadsworth. He is the president and CEO of Life Connection of Ohio, which serves families and saves lives through organ donation in Northwest and West Central Ohio. Before taking the reins of Life Connection in Ohio, he served as the vice president of clinical affairs at Nevada Donor Network. Under his leadership, Nevada Donor Network doubled its performance within 3 years. And next, we'll hear from Dr. Ray Lynch. He's a professor of surgery and public health sciences and the director of transplantation quality and outcomes at Penn State Health's Milton S. Hershey Medical Center. He is a transplant surgeon whose research focuses on improving access to organ procurement and transplantation care. And his work has formed the basis for objective metrics for assessing the effectiveness of organ procurement organizations. And our fifth witness is Ms. Donna Cryer. As the founder and chief executive officer of Global Liver Institute, the largest patient-led liver health nonprofit. She has channeled her experience as a patient in inflammatory bowel disease with a 28-year liver transplant recipient into professional advocacy across a career in law, policy consulting, public relations, clinical trial recruitment, and nonprofit management. She has been awarded the Distinguished Advocacy Award by the American Association for the Study of Liver Diseases and the Founder Award for the Global Genes among many of our accolades for her pioneering patient advocacy. So we'll start with Ms. Goldring.
Hello and good morning, Chairman Cardin, Ranking Member Young, and members. Thank you for this opportunity to testify before you today. My name is LaQuaya Goldring. I am currently dependent upon the U.S. organ donation system to save my life while I await a second kidney transplant. And in the meantime, the system is continuing to fail me badly. As a toddler at the age of 3, I was diagnosed with a rare kidney cancer that took the function of my left kidney. And when I was 17, I went back into complete renal failure, and I received a first kidney transplant at that time. Unfortunately, in 2015, I went back into kidney failure, and at that time, I wasn't ready for another transplant, but I didn't have a choice but to go back on dialysis. I've been waiting 9 agonizing years for a transplant, dependent upon a dialysis machine 5 days a week just to be able to live. I was told that I would receive a kidney transplant within 3 to 5 years, but yet I am still waiting. I'm undergoing monthly surgeries just to be able to get my dialysis access to work so that I can continue to live until I get a transplant. The UNOS wait list is not like 1 to 100 where everybody thinks you get a number. I'm never notified on where I stand on the list or when I will get the call. I have to depend on an algorithm to make the decision of what my fate will be. Every day that I'm waiting, I'm closer to becoming one of the 30 Americans who die waiting for an organ transplant. I know this all too well because that's why I've had to take matters into my own hands and start searching for a living kidney donor by starting a social media campaign. I've lost multiple family members and friends to organ failures, and I've seen more funerals than success stories, and I don't want to be the next. The reason it's so hard for me to get a transplant is because the government contractors running the organ donation system are failing and corrupt. I grew up in rural Kentucky where the organ procurement system, the OPOs, are now failing, as like many in our country, where over 28,000 organs every year are not recovered, and instead they go lost or they're wasted. More than 1 in 4 kidneys are thrown in the trash as generous families have offered to donate. And it's even worse for people that are labeled minority or people that are brown and black. Our kidney functions are wrongly calculated based on race, and it delays our access to transplant. OPOs are less likely to show up for us when it's time to get authorization for you to be a donor. The treatment that we get is less urgent and less care, and they're less compassionate toward us. I know this firsthand as my grandmother was an organ donor, and we had to personally reach out to the OPO just to show up. These failures lie at the feet of the monopoly UNOS. Patients like me completely go forgotten in a system that is failing us every day as more and more of us continue to die. Just a few weeks ago, a donor family had reached out to me to be a directed kidney donor, meaning they chose me specifically for a kidney transplant. But unfortunately, due to their errors in the UNOS technology, I was listed as inactive, and this was a clerical error. And all that they told me was this was a clerical error, and they could not figure out why I was inactive. but when it came down to it, I'm actually active on the transplant list. This wasn't a one-off event. UNOS technology is unsecure and unreliable, and it crashes hourly. And during that time, transplant candidates are not getting phone calls. While kidneys continue to go lost, lives continue to be lost in the process. Every time this happens, patients like me continue to die. You can't even imagine how this feels every time I lose a family member because of UNOS failures, every time I lose a friend, or every time I look in the mirror and see that I am standing with one foot in the grave and one foot hoping to be able to live to see another day, waiting on a call that may never come. As the email from the OPO CEO board member once said, the proposal once said systematically hurt minorities based on where we live and that we are dumb explicits for living in the South and rural America, as though we can choose where we live as we wait for a transplant. But this is never the case. While they're using taxpayer dollars to get specific trips, large salaries, going on golf tournaments and vacations and beach houses, patients that look like me are getting coffins. But there is never any consequences for them because the government has never held them accountable. The government has completely failed me, as well as many of us sitting here today. The only solution to replacing failing OPOs is to get rid of UNOS. Not tomorrow, not 2 years from now, but today. My fate lies in the hands of the Senate. My fate, like many other Americans, lies in the hands of you and all your constituents, and I'm just asking that you all stand behind this legislation as we move forth, and that all of Congress stands together to pass this new legislation so more lives can be saved and less can be put in coffins. Thank you.
Mrs. Goldring, thank you very much for your testimony. You've heard us mention the numbers that are out there, but there's nothing like seeing the individual that's impacted by that. Each number is a person. So I thank you for sharing your story with us. It's powerful.
Thank you, sir.
Ms. McCarthy?
Good morning, Chairperson Cardin, Ranking Member Young, and the members of the committee. I'm grateful for the opportunity to speak with you today. My name is Molly McCarthy, and I am an exceedingly grateful three-time kidney transplant recipient after having had my first transplant 32 years ago. I'm one of the fortunate ones. I've made it, despite the broken and corrupt system that we have been saddled with. And I am all too aware that many patients are not as fortunate. I received 2 living donations, one from my mom and the other from my dad, an option that so many patients just don't have. 11 years ago, I received my 3rd transplant from a generous deceased donor. And while I'm very healthy now, I am acutely aware that I may need another transplant in the future. And whether that happens is dependent on what Congress does now. I'm here today to plead with you to please pass 1668. And the reason why is as simple as it is heartbreaking. The federal monopoly contractor managing the organ donation system, UNOS, is an unmitigated failure. And its leadership spends more time attacking critics than it does taking steps to fix the system. I've seen this firsthand in my 5 years as a patient volunteer with the OPTN, and 3 years ago, I stepped into the role of Vice Chair of the Patient Affairs Committee, or PAC. I thought this would be a great opportunity for me to demonstrate my gratitude by representing and advocating for the patient voice to be included in national policy. I could not have been more wrong. What I have observed is that UNOS at best treats patients as props. At worst, it outright lies to us and then uses us as a shield against much-needed oversight and reform. Now, UNOS knows enough not to lie to Congress, so it lies to its patients instead and then launders those lies through us. It is no wonder to me that Forbes called UNOS a cartel in 1999. For the last year, much of my work with PAC has consisted of writing to congressional offices to fact-check UNOS misinformation, which I would like to take the opportunity to do today. For example, UNOS leadership has created a systematic effort to misrepresent the facts, regularly celebrating recent increases in organ donations as evidence of their success in a well-working system. The reality, however, is that this growth is driven entirely by the opioid epidemic, skyrocketing gun deaths, as well as other increases in suicides and fatal car accidents. All UNOS is celebrating are national tragedies, not evidence of a well-run system. Arguably worse, people who speak out have been bullied, threatened, and retaliated against. I personally have been warned by the UNOS board that it is unhappy with my criticism and that there may be consequences if I continue to speak out. I'm a 3-time patient. How do they say that to me? Further, I have been called by a board member telling me to stop focusing on system outage and downtime of the UNOS tech system. He told me that having downtime wasn't a big deal at all. The donors are dead anyway. That comment speaks volumes to me about the lack of empathy and respect UNOS has for donor families. UNOS has failed to oversee OPOs. As a patient, I cannot fathom why any Tier 3 OPO is allowed to operate. Our lives depend on this business, and CMS must immediately replace failing OPOs with the successful OPOs that are getting the job done. There is no shortage of evidence that this system is broken. What I hope to convey today is that the problems are far worse than publicly known, and the rot goes far deeper. While we may never know the true toll of the gross negligence and abuse of the government's own organ contractors, we at least know the solutions. CMS needs to move urgently to open data for OPOs. They must replace these failing OPOs without caving to industry pressure to weaken standards and close the dangerous pancreas loophole that allows OPOs to pad their numbers, misrepresent their results, and jeopardize patient lives. And 2, Congress needs to break up the UNOS monopoly by passing 1668, ensuring that HHS uses its authority to replace UNOS as its contractor. Before my last transplant, my family and I waited 6 agonizing years, and watching your hearing last August, we realized that potentially years of that wait were unnecessary. Patients deserve an effective, safe, transparent, and equitable organ donation system. Speaking as a patient, and after having had an inside glimpse into the culture and operating model, I have zero confidence that we will ever see improvement if UNOS has any role whatsoever in the transplant system. Thank you.
Well, Ms. McCarthy, thank you for your courage to come forward and to share with us the information that you have observed. Mr. Wadsworth.
Chairman Cardin, Ranking Member Daines, and members of the committee. My name is Matthew Wadsworth, and I serve as the President and CEO of Life Connection of Ohio, the organ procurement organization responsible for facilitating organ donation in Northwest and West Central Ohio. My job is to help as many patients as possible receive life-saving transplants. Most days, I try to do that through continually improving practice at our OPO. But to effect meaningful change at scale, we need federal policy reforms. The current system is broken. OPOs have geographic monopolies, which has made too many sluggish and complacent at the expense of patients' lives. There are absolutely no guardrails in place to ensure that OPOs are adequately serving patients, and many of them aren't. And yet, the Centers for Medicare and Medicaid Services has never once decertified an OPO for performance failures. In recent years, it appears things may finally be starting to change. CMS finalized new regulations in 2020 to hold OPOs accountable for the first time in 40 years. 3 years later, CMS still has not taken the steps to provide OPOs with any guidance on how the rule will be enforced or any indication that it will support meaningful competition to ensure that patients are only served by the best OPOs. Furthermore, CMS has remained silent on waivers filed by hospitals who want to work with higher performing OPOs now instead of waiting until 2026. Additionally, CMS has not taken any apparent steps to close a dangerous loophole in the rule which gives OPOs credit for recovery of pancreata that are never transplanted, pancreata labeled for research, which many OPOs have begun to flagrantly exploit, evidenced by over a 400% increase in the number of pancs placed for research since this new rule. This means that OPOs that are failing at their central task, recovering organs for transplant, can avoid accountability by simply recovering one organ and labeling it research. The fact that executives in our industry lack the moral compass not to exploit this loophole is perverse. I am deeply appreciative of this committee for investigating this particular abuse. This should be proof positive of a perhaps self-evident notion: OPOs respond to their incentive structure. Unfortunately, those incentives are currently entirely misaligned with what patients need. This is not only regulatory but financial. The OPO industry, including OPO boards, are often rife with financial conflicts of interest, which means OPOs all too often spend taxpayer resources on special interest projects rather than on investing in organ recovery. Another issue that deserves urgent attention is the lack of safety guardrails. There isn't even a standardized process for declaring brain death across the country. The reality is that the quality of care a donor patient and a donor family receives depends on where in the country that person dies. The fact that organ procurement system has been so broken for 40 years speaks directly to the complete abandonment of patients by the organization at the top of the system, UNOS. Even now, more than 3 years into this committee's investigation into UNOS's failures, UNOS has transitioned from an organization that's inept, possibly incompetent, to one that takes an active role in preventing patients from being transplanted. Take, for example, recent reporting in the Washington Post that UNOS is proposing changes to its terms of service which disallow external organizations from conducting data-driven research into the most effective ways to place organs for transplantation, even as our organ discard rates skyrocket. UNOS only appears to be doing this to interfere with the business of a potential competitor for its contract, showing that once again, the system has been held hostage by a terrible actor, one which values its own contract far above the lives of patients that we're meant to serve. This is a perfect microcosm of the problem. At every turn, UNOS stifles innovation and hides its deadly failures, all to keep its monopoly contract. There are 3 things the Department of Health and Human Services needs to do immediately to ensure that patients receive safe and high-quality organ procurement care. 1, prepare to enforce the OPO rule without weakening or delaying it, including closing the pancreas for research loophole, publishing guidance on how the rule is going to be enforced, and requiring the publication of OPO process data. 2, break up the OPTN contract and allow for competition. Patients need to be served by the best in areas such as technology, logistics, data analytics, business development, and process improvement. And 3, eliminate board and financial conflicts that exist in our industry that prevent OPOs and any OPTN contractors from investing their dollars in areas that grow donation and transplantation. I commend this committee for introducing legislation to finally break up this monopoly, and I stand ready to work with you in any way possible to ensure that this bill passes. It's the only way this industry will be able to save more patients' lives. Thank you.
Well, thank you very much for your testimony, particularly as it relates to accountability and competition. We appreciate it very much. Dr. Lynch?
Chairman Cardin, Ranking Member Daines, and members of the committee, my name is Raymond Lynch. I'm a liver and kidney transplant surgeon and a professor of surgery and public health at Penn State Health and Penn State College of Medicine in Hershey, Pennsylvania. Thank you for the opportunity to speak today. In my career, I've had the privilege of recovering organs from more than 200 generous deceased donor patients. I've performed hundreds of organ transplants, and I'm the principal investigator on an NIH-funded study to enhance organ procurement care for United States veterans. I'm here because Congress has the ability to take action to save my patients' lives. I ask the committee to take concrete steps to make organ procurement and transplant safer and more effective for all patients by supporting legislation that permits authentic competition for the OPTN contract, allowing specialized, highly skilled organizations the opportunity to move our transplant system into the 21st century. By ensuring that CMS and HRSA collect and report data on how OPO workers provide clinical care, and by ensuring that CMS enforces the current OPO performance threshold without delay or dilution. I want to differentiate between organ donation, which is the altruistic decision of the donor patient and their family, and organ procurement, which is the clinical care provided by OPO staff. This is what turns the gift of donation into the usable organs for transplant. Organ procurement is a clinical specialty. It's the last medical care that many patients will ever receive. It's reimbursed by the federal government, and it's administered by OPOs that are each the only provider in the territory to which they hold federal contracts. Right now, patient care delivered by OPOs is some of the least visible in American healthcare. I can't tell you how many patients were evaluated by OPO workers in the U.S. in 2022. I can't tell you how many patients were examined, or how many families were given information about donation, or how many times an OPO worker even showed up to a hospital to do this clinical duty. This lack of information about what OPO providers actually do for patients is the root cause of the variability in rates of organ procurement around the country. My research has shown that what we call OPO performance is a measurable restriction on the supply of organs that results in the unnecessary deaths of patients with organ failure. For example, if the lowest performing OPOs from around the country had just reached the national median over a recent 7-year period, there would have been 4,957 more organ donors, yielding an estimated 11,707 additional organs for transplant. Because many OPOs operate in a low-quality data environment and without appropriate oversight, almost 5,000 patients did not get adequate organ procurement care, and nearly 12,000 other patients did not receive life-saving transplants. Patients like Ms. Goldring, Ms. McCarthy, and Ms. Cryer carry the burden of the failures in the system. OPO clinical work is currently not visible, it's not benchmarkable, and it's not able to be adequately evaluated, analyzed, or compared. However, much of the hidden data about how OPOs provide care to patients is known to one entity, and that entity is UNOS. The frontline OPO providers who administer procurement care are some of the most dedicated and hardworking in medicine. Instead of offering these workers assistance, UNOS has instead advocated for a deadly status quo where fear-mongering takes the place of action to address quality of care. Even worse, UNOS claims recent increases in organ donors as a measure of its own success. I have published peer-reviewed research that reveals a primary driver of the large portion of these increases to be the opioid epidemic. Between 2009 and 2018, 94.6% of the increase in the number of donors came from patients who died from a drug-related cause. This does not lessen the value of these donor patients' gifts, but it does make the appropriation of their tragic deaths as a success story for government contractors a lot harder to stomach. UNOS is not capable of managing a safe, effective, and innovative transplant system. I know many of us have served to the best of our ability on UNOS committees, and I emphasize I direct my critical comments to UNOS leadership and to their network of cronies. In spite of our best efforts, UNOS incompetence prevents patients from becoming organ donors or receiving transplants. We need a new network of highly skilled specialist organizations, each attending to areas of expertise in the management of the OPTN contract. I ask you to listen to patients, to researchers, and to frontline healthcare workers at OPOs, transplant centers, and community hospitals. I ask you to remove this burden from the patients and to put a new OPTN contractor to work. My patients' lives depend on it. Thank you.
Dr. Lynch, again, I thank you for your willingness to come forward with this information. It's very helpful to us. Mrs. Cryer?
Thank you, Mr. Chairman, Ranking Member, and committee members for your bipartisan support and commitment to saving the lives of the more than 100,000 Americans waiting today for an organ transplant by passing legislation to break up the deadly federal organ transplantation monopoly. My name is Anna Cryer, and I am the CEO of the Global Liver Institute. I founded this organization to ensure that other patients and their families would have the same life-saving opportunity that I had, because we know too many do not. It seems I have waited decades to give this testimony, and I know only by the grace of God am I alive to give it. Since my own life-saving liver transplant nearly 3 decades ago, I have worked in the organ donation and transplantation field and seen the system from all angles, as a patient, as a lawyer, as a nonprofit executive, as a federal government appointee, and having served in several roles as a UNOS staffer and volunteer. And so I know that the fault for thousands of unnecessary deaths and so much dysfunction lies squarely with the United Network for Organ Sharing and the federal organ donation and transplantation monopoly contractor, which has held this contract since 1986. I applaud this committee's investigations for helping us, all of us here and so many others around the country, to pull back the curtain finally and show every American citizen the corruption that lies beneath this. My first role at UNOS was as a patient affairs specialist, which gave me views into policy, education, communications. I even drafted the board minutes, so I know what the conversations were going on. Years later, as a member of UNOS's Membership and Professional Standards Committee, or MPSC, I was charged with reviewing patient safety lapses and generating remediation plans. I hope this was finally a place where I could make a difference. But as the Senate Finance Committee's investigation has revealed, UNOS executives joke that, quote, it's like putting your kid's artwork up at home. You value it because of how it was created, whether it's well done, end quote. This is consistent with my firsthand experience. The joke, I guess, is that UNOS knowingly leaves patients unsafe and unprotected. I fail to see the humor. What I experienced firsthand was that MPSC decisions were made by a small cabal of industry insiders protecting each other, routinely ignoring or excusing aberrant and dangerous behaviors. The patient in me was traumatized. The lawyer in me was wondering at what point would HHS staff in the room do what they were supposed to do and oversee the overseers? When would they step in and act? They never did. We can change that today. UNOS has been well aware for decades of severe and often fatal risks to patients and has worked far harder to cover them up than to fix them. And there is no reason to believe that UNOS has changed since then. Many of the same executives are not only still there, but they have been promoted. For example, the current CEO, Maureen McBride, has been there since 1995. How is that a change agenda? We have the opportunity today, though, to create a different future for patients and families. Transplantation is often painted as complex, but a very few simple steps would make the system significantly safer and equitable and would elevate the quality of organs available. Congress needs to pass the Securing the U.S. Organ Procurement and Transplantation Network Act, period. Secondly, there are acts that CMS can take, long-awaited acts that they can take. Some examples are simply to enforce regulations, to hold OPOs accountable for their performance, and to do so without caving to industry, lobbying pressure to weaken these standards in any way. Openly publish OPO and process data, require that all staff interacting with patients have some baseline clinical training or licensure. That should not be too much to ask for, and to require that adverse patient events are publicly reported. Innovation and reform will never come from the same people paid lavishly to perpetuate the status quo. They will push back as they always do, and protectionist arguments will be made that change is disruptive. But I assure you that nothing is more disruptive than dying. At my sickest point, doctors stood outside the ICU and told my mother that I only had 7 days to live. Right now, 210 people are estimated to die in the next 7 days. They will not be saved by empty promises that reforms will come years down the line. They need you, senators, to act today. Thank you.
Well, thank you for, Squire, for your testimony and laying it on the line with us. The five of you have presented very powerful testimony. And there is general consensus among, not general, there is consensus among the five of you of what we need to do. It really does reinforce our initial thoughts. Our legislation that we filed that would open up competition, your assessment that the OPOs are not being held accountable, too many on Tier 3, one is too many, and that as a result we don't have the outreach and procurement that we should have in our communities, which is costing people's lives. The inability of UNOS to modernize, you're not alone on that. The United States Digital Service found that UNOS is incapable of modernization. And then the lack of transparency. We don't have the data. We don't have the information. Ms. Goldring, you can't get adequate information as to where you are on a list is unacceptable. The anxiety of that issue alone and the pain it causes you and how it affects your health is something that cannot be tolerated moving forward. So normally I have a lot of questions I want to ask. I want to ask a couple, but you really reinforced, I think, our views of the need for our legislation, but more importantly also the need for accountability. CMS needs to enforce the rule that was adopted that would hold OPOs accountable and decertifications if they don't meet the test, and opening up competition that all of you have talked about being so important that we have. All that is just so important. Then, of course, without the data, we get, our investigation showed that there was transportation delays, that the IT was down for a period of time. And if you're down for a couple hours, that's, if I understand it, maybe I'll ask Dr. Lynch this, about the timing, how important it is to get time, immediate time information here. So if you delay, if IT is down or the transportation, you can't track where the organ is, what impact does that have on a successful transplant?
Life and death.
That's a pretty direct answer. And that's happened over and over again. Or if an organ's not properly sampled from the point of view of disease, what impact does that have?
Potentially life and death, Senator.
Yeah. And these are the mistakes that are routinely being made too often. We've been told that the error rates on transportation are higher than we have on the private companies that you can just go to the neighborhood and have, you can track your packages better than you can track organs in this country. I guess I'll ask a question on transparency. You've all talked about it, but that's an area that I find incredible, that you can't get the data and information about a lot of this because it's just not available. Is that what I'm hearing?
I'll answer that. Speaking to the recent reporting in the Washington Post, I mean, UNOS is obstructive to it. The idea that we wouldn't use this data, aggregate it, and use it to drive process improvement and save patients' lives, I can't understand that. We have the ability to do it. Let's analyze it so we can do better.
And then the IT modernization. We all have modernized our IT except in this area. I don't understand why there has not been the progress made. Mr. Wadsworth, you made specific recommendations, and we made notes about that, and all of you have. I can tell you that we will be working on a dual track, one, legislation, but two, also accountability and enforcement by HHS, which that's the reason why we had our roundtable discussion last week with HRSA and HHS, CMS, to make it clear that we expect enforcement. HRSA is responsible to make sure that we have accountability, and we don't have accountability in the current system. That is clear. There's general consensus that UNOS has failed. We recognize that, and that has to be first and foremost. Secondly, we do need independent boards, and I know they're moving forward on that point. We don't want to have conflict boards. Third, transparency, and fourth, competition, and then accountability for those that are not performing. Senator Young.
Well, thank you for your riveting testimony, especially to our patients, but really to everyone. I thank you. This is very helpful in generating additional attention towards this issue and helping us affect change. You know, since I got involved in this issue, I was told time and time again from UNOS, from HHS, from other interested parties that somehow management principles didn't apply. They couldn't be applied to this endeavor of procuring organs and matching them up with individuals for life-saving treatments. This was different. It turns out that the basic management principle, if you can't measure it, you can't manage it, also applies to this setting. What is different is UNOS has had a monopoly. And we don't allow monopolistic behavior in other areas, but we have allowed it far too long in this area. And we've seen it manifest itself in lost lives, anxious individuals, and incredible professionals who are trying to do the best they can within this system. Dr. Lynch, you have really broken a lot of ground in measuring what we can, right? And indicating what needs to be measured more effectively. I thought it was really compelling when you were talking about this clinical practice that is so opaque. It seems to me there's an incredible opportunity if we can get this legislation passed to shine some light on that practice and to begin measuring and therefore more effectively managing this entire enterprise. So I see the possibilities here, and I'm excited about those. Dr. Lynch, there seems to be overwhelming evidence that there are significantly more organs available for donation today than are actually procured. Has UNOS or OPTN made any meaningful attempts to increase the number of organs that are procured?
No, Senator. UNOS did not make any comment on the final rule that went into effect in November of 2020 until April of this year.
We can remedy that. Mr. Wadsworth, I was looking at you when I was discussing these individuals who've done yeoman's work within the parameters you're given, within this ecosystem to try and make improvements. You've done it at Life Connection of Ohio, some of your previous work. What were the most critical changes you implemented that have led to improvements? Can these changes be replicated or shared with other OPOs? And then where I'm leading with this is, does anyone give you a venue to share those practices? And shouldn't that perhaps be the role of the OPTN?
We actually used a lot of Dr. Lynch's work in our analysis of Life Connection when we first got there. And what we did was we built structures to capture what the potential, what the data said the potential was. So yeah, this absolutely can be replicated. We've done it twice. We did it in 3 years in Nevada. We did it in 2 in Life Connection with our amazing team there. So yeah, it can be replicated for sure.
And what role should the OPTN be playing in helping to facilitate some of the sharing of best practices?
Yeah, so to answer your second question, no, I don't have a venue, and it's probably because I'm looked at as a little bit of a pariah given the House testimony in 2021 and saying the things that probably should have been said a long time ago, and I'm sure I'll get some backlash here for this. But no, I don't have a venue, but one thing we talk about internally is our organization will share any practice, anything we do with any organization that asks, and we don't need credit for it, just save someone's life. So, but no one ever asks. It's crazy to me.
Okay, I'll have some more questions. Chairman?
Senator Blackburn.
Mr. Chairman, thank you so much. And I want to thank each of you for being here. We had an insightful roundtable last week as we started looking at this issue. And to Tennesseans, this is an important issue, is getting this right. And Mr. Wadsworth and Dr. Lynch, I so enjoyed my few moments of conversation with you all. And Dr. Lynch, I think I want to come to you first. And when we look at OPTN and look at the Securing Organ Procurement, the Act, the bill would strip the nonprofit requirement for the manager of the organ procurement and transplantation network, which would open the door for profiting from organ procurement and donation. And to me, this is something that I think many people really fear, especially people that are on a wait list. And so what I would like for you to do is to address that and address those concerns and why or why not you think the Act has it right.
Thank you, Senator. I think it's unfortunate that people would be afraid of that, and it needs to be changed. Many of the patients that you reference are waitlisted at for-profit hospitals. For-profit is a part of American healthcare, and I can tell you that our not-for-profit entity, UNOS, doesn't work, and there are for-profit hospitals and for-profit transplant centers that do work. So patients don't need to be afraid of that. They do need to be afraid of the status quo.
Okay, thank you for that. Mr. Wadsworth, we've talked about the OPOs and what they could or could not do to follow HRSA's guidance on modernization, and you've talked a little bit about that. So when it comes to leveraging some of the modernization efforts and trying to enhance transparency, competition, and overall efficiency in the system, what do you see as the most vital steps that should be taken so that we're moving toward that goal?
For me, I think it's mostly around the data analytics, the business development of the organizations to be structured in a way that they can capture the most potential possible for the patients that they serve. And then also utilization of technology to then, for that application of it.
And then address the issue of patient privacy. And as you look at data and how some of that data that is captured and shared, and then how that moves into research, what is the importance of anonymity and privacy for those patients?
It's always going to be important to protect patient data, and it's personal. But if we can, there's ways to look at the data that blinds that, and it's still going to drive process improvement without having concerns of sharing something that shouldn't be shared.
Okay, Ms. McCarthy, did you want to weigh in on that?
I absolutely agree. Obviously, we need protection of our personal data, but right now, everybody hides behind that, or UNOS hides behind that as reason not to share with us information. In the context of waitlist accuracy, our PAC several months ago made a request for data around how many people are actually on the waiting list and whether it's accurate, knowing that 40% are inactive. We were told as recently as last week that we will not be able to see any future movement on that for no less than 8 months, despite it being anonymized data, but we were just completely told that we couldn't do it, despite coming in with the spirit and tooling to be able to find some opportunities to improve.
All right. Dr. Lynch, anything to add on that topic?
So the responsible use of patient data is a key part of healthcare research, and it's something that happens in other fields. This is something where we do take on the public trust to do that, but it's a recognized way to move forward, and saying that it's a stumbling block or an absolute no is simply false.
And do you fault UNOS in that regard?
I do.
Okay. Thank you all. Thank you, Mr. Chairman.
Thank you. The lack of transparency here in data makes it difficult for us to understand all of the challenges that we have. But I take a look at the waiting list and the numbers that are come off the waiting list with an organ, and the percentages in the non-Hispanic minority racial communities versus the rest. It's much, much lower chance of getting an organ. And I tried to find out why that's the case, whether it's the ineptness of the OPOs that are in those regions, or whether it's UNOS's issues. But I know that there is a disparity here, and we need to do something about it. Ms. Goldring, you have experienced and currently experience the frustrations of being on a wait list and not being able to procure an organ transplant. Can you just share with us some of the experiences that you've had in regards to being on that wait list?
Excuse me. Yes, Senator. In regards of being on a wait list, I've gotten to a point to where I sit by the phone and wait and just wait, basically. Every day you're waiting for that chance to be able to get that one call, and it never comes. And so we're stuck battling the state when it comes to insurance. As somebody waiting on one transplant list, you want to be able to secure an organ in another state. Well, if I want to go to another transplant team outside of the state of Kentucky, I'm stuck dealing with the medical side of trying to figure out how can I qualify to go to the next team in response to not having protections against insurance discrimination. On top of the failures of UNOS, not calculating my GFR correctly, it delayed my process of being listed a whole year sooner for transplant. So I'm stuck on dialysis until I actually get that transplant. And then in the process of going and seeing various transplant teams and working with the OPO in my state, I've managed to talk to them about discrimination while still being discriminated against. And when I ask the same question, why are Black and brown people, or just anybody that looks like me, are not being transplanted, they have no answer other than, well, we need more Black donors. And my response is, why do we not see you in the hospitals actually securing organs for us? When it comes down to it, organ donation is not about your skin tone. Organ donation is about an individual looking for another chance at life, and that is all I'm asking for, a chance at having.
Ms. Cryer, do you have any views as to why it's much lower percentage chances for a racial minority to be able to have a transplant?
Yes, and it really does come down to UNOS not doing its job of overseeing the organ procurement organizations. We know that from many studies that Black and brown communities donate organs in the same percentage they are of the population. So it is not a problem of willingness to donate. It is a problem, as Ms. Goldring was starting to discuss, about UNOS and OPO, not ensuring that OPOs go out into the communities, develop relationships far before that horrible decision is needed to made to donate the organs of a family member. Also, this underscores the importance of the transparency of data. If we don't have granular data that shows those specific disparities, whether it's racial and ethnic or rural and urban, we really can't solve the problem and continue to improve.
Mrs. McCarthy, do you have any view on this?
This is a topic that's been near and dear to the heart of our PAC for quite some time, and more than a year in advance of any movement on the EGFR calculation being racially biased, we raised this time and again with the UNOS leadership as something that was disadvantaging Black patients. We were ignored. We were told to stop talking about it and bring it up, that it was a far too complicated topic for them to address, and basically we were dismissed. Although now, as a result of some of the movement forward, there's now a class action lawsuit by 27,000 Black Americans to actually hopefully make right that which has been obviously a disadvantage for them.
Either the two of you want to comment on this? Be glad to hear from you.
So this is a multi-layer problem for which we need interventions at every layer. What we know from within the transplant community is that UNOS has failed to help us with data, and this is why it's so important for CMS and HRSA to require the recovery of data that's already being collected at centers and OPOs on processes that go from before the waitlist decision or from before somebody becomes a organ donor patient. So data will help us to address the parts of it that we can address within transplant.
Absolutely. Senator Cortez Masto.
Thank you, and thank you to the chairman and ranking member. Such an important issue. So appreciate your work here, and to the panelists for being here. And Ms. Goldring, I want to thank you for being here today as well and sharing your story with our subcommittee. I think we all agree it's critical that we understand your experience, the experience of many across this country, and really try to fix or at least address what we're hearing are some of the concerns. Let me follow up on Senator Cardin's questions around transparency. Unfortunately, as we all know, we have a tremendous lack of transparency when it comes to the U.S. transplant system. And even when information is made available, and I hear this in my state, it is difficult to find and hard to understand. This fosters mistrust and reinforces the complexity of navigating a transplant network, a system that should be, I believe, and I think many of us, as transparent as possible. Dr. Lynch, what role does increased transparency play in impacting the quality and outcomes of the transplant system? And how can transparency help make sure the United States transplant system is really more equitable, as you were talking about?
I think we have a tremendous opportunity right now, Senator. I think this legislation is going to be central to that. Getting specialist organizations that will help us to rebuild trust within the community and for our patients is going to be a part of it. And then getting that, what we call process data, to understand how we're delivering care to various, socio-demographic groups, to various geographic areas. All that's going to be central into how we help the patients with organ failure, how we respect the decision to become an organ donor patient for those people who have passed away, and how we make the best and most efficient use of all the resources we have.
Thank you. And let me just ask the panel in general, in recent years, some organ procurement organizations have implemented new practices really to the success of their region becoming high-performing OPOs. However, I recognize that many are failing to meet some of our most important measures of performance, and quite frankly, that's why we need to move forward with these much-needed changes. And this is open to the panelists. From your perspective, is there a balance to consider here? Do you believe we should be working on maintaining and promoting the success of Tier 1 OPOs while moving forward with broader reform? And Mrs. Cryer, you can start. Thank you.
Nothing that we are contemplating today would disrupt or disallow those who are performing well from continuing to performing well. All it means is that we will have more OPOs who are operating at that level. As Mr. Wadsworth is a perfect example, leadership matters. So, and it's so important to the point that you made about equity as well, to ensure that every American, wherever they are in the country, has the same chance at a life-saving transplant and the same respect for their donation as well, no matter where they live. And we can't do that without the legislation, the changes we're asking for today.
Thank you. And I noticed, Mr. Wadsworth, you had mentioned the improvements of the OPO and an OPO in Nevada as well, and I'm curious about your comments.
If you look at the data and you watch it, you can see who's trending and who's taking it seriously. And if you remove the pancreatic for research loophole, you can see whose improvement is genuine. Now, I don't think giving anybody more time, their behavior is going to change. They are who they are. I think another evidence is, I don't think it's a coincidence that a lot of CEOs retired the moment this rule was announced because it got hard, right? That shows a lack of leadership in our industry. When stuff gets hard, you lead your organization through it and you help patients. You don't exit stage left and leave someone else holding the bag. So I don't think behaviors are going to change. The easy way to make your organ procurement organization look better was to take advantage of this pancreas for research loophole. And as I said in my opening testimony, that's absolutely perverse, and that someone would actually do that and be in a position of leadership and their board not act on that, that's extremely troubling. We shouldn't give them an opportunity to move tiers because they can do that and then exploit it even further on a larger population base.
Thank you. Ms. McCarthy, did you have anything to add?
As I said in my opening statement as well, as a patient, I cannot fathom why we have any of these Tier 3 OPOs that are being allowed to exist. For me, I would like to see them close down immediately, transfer the responsibility to high-performing OPOs who also happen to have high-performing leadership, and make those changes now. I think that's the only way we're going to start to see some material impact to patients.
Thank you. Thank you again for being here. So appreciate it.
Senator Young?
Thank you. I just want to rejoin something you said earlier, Ms. Goldring. I have to tell you, I'm stunned to hear your comments that you randomly discover that you're listed as inactive on an organ waiting list. It's horrifying. It ought to send chills down the spine of anyone who's watching this hearing. You were blocked by our U.S. government contractee from receiving life-saving organs. This, if anything, highlights to me the urgent need for reform. In the wake of this horrible discovery, are you aware if there was any attempt from UNOS to notify you that your status had changed to inactive?
Excuse me. Senator, to answer your question, no. UNOS never particularly contacted me nor the hospital to say what the actual problem was that happened, and I was never apologized to. And so I ended up having to talk to the actual family who wanted to donate to me.
They just said it was a clerical error. I'm sorry for interrupting. A clerical error.
Yes, sir.
Clerical errors happen. Was anyone held accountable?
No, sir. And all that I was told is, well, sometimes this may happen, but we'll do what we can going forth to make sure it doesn't happen to another patient. And that's all I was told about the situation. and that was from an executive director of an OPO.
This goes back to basic business principles. When there are really important tasks to be done, there are mechanisms that can be put in place administratively to highly minimize the number of clerical errors that could occur, for example. Ms. McCarthy, is there any formal policy about when and how to notify patients of this important status change from active to inactive?
To the best of my knowledge, there is a policy that we are to be told of any changes in our status by U.S. mail letter. Speaking as a patient who's been on the list 3 times, and many patients that I've talked to as well, none of us have any recollection whatsoever of actually receiving any of those letters. As recently as last August, our PAC spent 4 hours doing a design thinking workshop around how could we solve this problem using technology. I asked as recently as last week what the outcome of that was. I was told by the UNOS leadership that they are not allowed to tell me, but that I'm going to really, really like it. But as I've done more digging, there's absolutely no movement forward in that.
I mean, so your PACs come up with all sorts of ways to avoid this, right?
Countless. We've proposed, yes.
And with the highest degree of respect, you're not probably populated with NASA engineers and well, maybe you are, but nonetheless, I bet I could sit down and probably come up with some guardrails here. So, but it's not my job. Today, it's the job of UNOS. And if we have our druthers, if this panel has its druthers, and anyone watching this proceeding has their druthers, UNOS won't be doing this for very long.
God willing.
I've got about a minute left, and I want to make use of our time together. So, Dr. Lynch, what does CMS need to do to appropriately enforce the 2020 OPO rule?
They need to move forward with this as quickly as possible, not dilute it, not delay it, not risk adjust it to make it less effective.
What do OPOs need from CMS in order to improve performance for Tier 2 and Tier 3 OPOs?
So they need honesty. They needed that 2 years ago when UNOS had the ability to give that to them. It's really important to reiterate, and this is in answer to Senator Cortez Masto as well. There is no requirement under the CMS regulation that any OPO go out of business, that it be decertified. The OPOs are being judged against what's being currently performed by their peers, and so this is something that they can achieve if they look and see what's happening to their next door neighbor.
Thank you. We've got some work to do up here and within this body, and we owe that to all of you to keep pressing hard. Chairman?
Well, just to follow up, Senator Cortez Masto, do you have an additional question? Just to follow up on Senator Young's point, you responded, Dr. Lynch, to enforce the rule, and we agree with you. That means there should be considerations of decertification if they're not performing at a level that's acceptable. But you also have to have the services available in a community. So you need to have competition. You need to have the ability to not just decertify, but to make sure there's access to transplant services in the community. So we don't want CMS to hide behind that issue and say they're never going to enforce this rule. And I think that's our major concern, because we find a reluctancy right now to pull the decertification trigger, which may, in fact, be necessary.
I think that's critical, and I think that having this legislation go through and getting a responsible contractor or set of contractors will take some of that burden from you. So with all due respect, I don't want us to have to keep coming back to the principle.
Yeah.
This is something that we should be figuring out in our own community, in our own transplant system, and with the right oversight and regulatory contractors, we can.
We agree completely with that. I'm just pointing out that I think the hurdle is not as, we haven't yet convinced CMS to be very firm about these dates and to have accountability if there is not the performance improvements that are expected under the rule that was issued. And the second point, Senator Young, your point to Mrs. Goldring, is that she found out, you found out that you were deactive on the list and you were able to get it corrected. But I am equally certain that there have been other cases similar to yours where the individual did not know to correct it, and that person may have ended up deceased. The point that Dr. Lynch, in response to several of my questions, delay equals life and death. Mistakes are life and death. So we are dealing with an urgent issue. The Chairman Wyden said that over and over again. This is urgent. Every day we're losing people. And it's just extremely upsetting and unacceptable to know that a clerical error that should be able to be easily caught by technology that's available today would have prevented that from happening, or that tracking of transportation, which technology is pretty sophisticated today, why that's not being utilized. As a result, it's very possible that lives, well, we know lives could have been saved that have been lost as a result of those types of mistakes. Well, you've heard Chairman Wyden and Senator Grassley and Senator Young and myself, and as well as the other members of our committee, make it very clear that we intend to treat this with urgency. Your testimonies have been powerful, as I said before. We sit through a lot of hearings. You have really motivated us in your testimony. All five of you have been very effective. We know it's not easy for you to be here, and know professionally it's not easy for you to be here. We know that it's uncomfortable to go through some of these stories. But as I said earlier, when we look at numbers, yes, we're motivated by numbers, but we really are motivated to action by seeing the people that are directly impacted by the policies that we have here. So I just really want to underscore again our thanks for your participation in this hearing. It is one that reinforces what we want to get done, but now I think gives us an additional impetus to move as quickly as we possibly can. Chairman Wyden mentioned we're also working with Chairman Sanders of the HELP Committee, because we recognize that we have to work with two committees here in regards to these issues, and Senator Sanders has expressed strong support for the efforts that we are committed to doing. I know there are a couple other members who wanted to be asking questions that are en route. I'm not going to hold up. Do we have any updates? We're going to just be a little patient for a few minutes, if you don't mind. We have a couple other members who really want to weigh in. This is an important subject, and I want to make sure our members have a chance to express their views. So if everybody will be patient, we will just stay in a quiet moment to reflect, and we'll be back very shortly.
That's all right. You got here quickly.
As I was saying, there's a lot of interest of members of our committee on this subject, and Senator Langford has been very active in these discussions. And if Senator Langford is ready, I will call on Senator Langford to inquire.
Thank you very much. I apologize. I was literally running back and forth on the floor. We're dealing with pharmacy benefit manager stuff. That's some of next week as well. So I appreciate y'all's engagement and the help on this. I need help and clarification on this, and it deals with the kidney side of the transplants. About 1% of our federal budget goes towards this issue. I mean, it's an enormous amount of money. There seems to be challenges here in multiple areas, both of getting kidneys to people in the process of actually doing the transplant, other treatments for all the kidney diseases and the whole multitude of those things out there, especially for diabetics and others. There's a lot of challenges here. Help unpack this for me, and what am I missing on this, and what can be done?
I think Dr. Lynch can weigh in on a little bit on the transplant center side, but a lot of the incentives just don't line up. So from the OPO side, it has a lot to do with, I mean, what are you going after, what cases, how are you pursuing these cases, and are building your organizations in a way that you can ask these families for the gift of donation and then manage these patients and getting the kidneys, getting the patient to surgery to remove kidneys for transplantation. I think the way things have changed in terms of financial incentives and things like that, and then I think transplant centers are incentivized differently, and I think they have their own challenges. So you have the OPO trying to push for increased kidney transplantation, and I think, and correct me, but transplant centers are more rewarded a little bit for being more conservative. We're lucky in Ohio that we have one of the best transplant programs in terms of wait lists and things in the country. So, but maybe Dr. Lynch can weigh in on this a little bit.
So yeah, I'm trying to find the incentives here and where we are. So Dr. Lynch, go ahead.
So renal failure is a crisis in America as a result of the epidemic of diabetes and organ failure. The difference in the incentives is that the OPO is incentivized, or ideally will be incentivized, to recover as many donors as possible. The center is incentivized to do as many transplants as possible, but is also measured on both its pre-transplant and post-transplant mortality. We need to make sure that there's a continuous chain of custody in these incentives so that they really do align, and so that we take the best care of the donor patients, we get every potentially usable organ recovered, and then get it to the recipient who can make the best use of that. And we make sure that centers are incentivized to take, what in some measures would be considered a risk, both with a riskier patient and a riskier organ, to give them that chance at longer, better life.
So tell me what that would mean as far as the incentive shift there. What would that look like? I understand what you're saying. Practically, what would that look like?
So ideally with better contractors as a result of this legislation, we would have a contractor that would measure everything in transplant, looking at our pre-transplant listing policies and looking at our pre-donor evaluation policies of who the OPOs are seeing as donor patients. And what we would do is make sure that every organ that is recovered is expedited to the best possible recipient for it, and that centers are able to remain competitive so that they're not routinely being pushed down the list or preempted in order to retain access for their patients.
So at this point, you're assuming, or maybe rightfully so, that there are some individuals that there may be a kidney available for them, but because they're considered a higher risk, they're kind of set aside.
Yes, sir. So for example, if we hypothetically were to measure centers only on their pre-transplant mortality or their post-transplant mortality, it will make centers conservative, and they will not list people who are at a higher risk of not making it to transplant, so dying before, or of not surviving as long after. But they deserve that chance if they're medically able to get both those options.
Mr. McCarthy, you're nodding your head over here.
This is an area that PAC has really stepped forward in as well, in terms of allowing patients an opportunity to have a voice, to be included in those decisions. There are some patients who are more willing to take a more at-risk organ in exchange for not waiting so long. So definitely something patients would advocate for.
Okay. Y'all, thank you. Anyone else make a comment? Yes.
I would just say that there are two ways to, I think what you're really asking is to reduce the costs of the ESRD program. And so I think there are really two ways that the work that we're doing here today do that. If you have fewer people who who run into renal failure, you really have to focus on, and I know CBO has a hard time scoring prevention. And so we have to find a way to be able to, I know we've been discussing, TROA and other things to reduce obesity, to reducing diabetes. Most patients are not controlled for their hypertension, particularly black and brown patients. At the Global Liver Institute, we have more advocates coming from Oklahoma telling us of the issues in Native communities of being able to deal with these issues that drive the need for transplantation. To the point of incentives, the incentives are to keep people on dialysis, not to transplant.
Right.
And so the ESRD program would be relieved if we had, on both ends, people being swiftly moved to transplant instead of languishing on dialysis and preventing the drivers of renal failure in the first place.
Okay, that's extremely helpful to be able to walk through, because we do have to fix the incentives in the process that are pushing people towards dialysis long term, rather than trying to give them the opportunity to have a much higher quality of life. Thank you.
Senator Warren?
Thank you, Mr. Chairman. The Organ Procurement and Transplantation Network, or OPTN, was established by the federal government to manage the U.S. organ donation program. And today, OPTN is run by the United Network of Organ Sharing, or UNOS, which is the only entity ever to have been awarded this federal contract. Last year, the Senate Finance Committee released the findings of an investigation into UNOS that revealed that this system is deeply broken. Organs are getting lost in transit, infected organs are being transplanted into patients, and the individuals responsible for running the system are riddled with conflicts of interest. So let's talk about one of these conflicts. Federal law requires OPTN to have a board of directors. Makes sense. Most organizations are governed by a board of directors that, when working properly, serve as a check on the organization's performance and management. Ms. McCarthy, you are a transplant patient yourself, and you serve as vice chair of the OPTN's Patient Affairs Committee. So you see up close the governance of the OPTN. So tell me, Ms. McCarthy, is there any difference in membership between UNOS Board of Directors and the OPTN Board of Directors?
Senator, there's not. They're absolutely the same people.
So they are identical, right? And right now, that means the same people are in charge of overseeing how well the contractor runs the organ donation system, and those are the same people who are actually running it. So, Ms. McCarthy, how does this governance structure affect the integrity of the organ transplant system?
I would argue there's no integrity in the system. There's no accountability, there's no transparency, and sadly, the cost of that is that people are dying every day.
So what you're telling me is nobody holds themselves accountable?
Absolutely not.
Because this is an identity of interest. Okay. My view on this is that OPTN changes are long overdue. And I support the reforms to HRSA, the federal agency that oversees the OPTN, and it was announced earlier this year that we're going to move in this direction. I also joined Chair Wyden in introducing legislation to give HRSA additional statutory authority to strengthen government oversight. And among the many reforms, the legislation would support HRSA's proposal to break up the OPTN monopoly contract into multiple smaller contracts, which would allow some competition and allow the best vendors in the business to manage different parts of the transplant network operation. That means hiring IT experts to do the IT. It means hiring logistics experts to do logistics, and so on. Now, UNOS does not want to lose control. So they're pushing to have the government limit eligibility only to nonprofit vendors that have worked in the past on organ donation. Meaning, for instance, that the IT company that is hired to run OPTN's computer systems would have had to have worked on an organ transplant network in the past and be a nonprofit. So, Ms. McCarthy, the requirement UNOS wants would seem to make it so that only one organization could apply for the new contract, UNOS. Would you have any concerns if HRSA awarded part of the OPTN contract to an entity that does not fit that narrow description?
Senator, absolutely not. Quite the contrary. We need to have diversity so that we can have the best in class serving patients.
I'm glad to hear this. You know, I think what we're seeing here is nothing more than UNOS trying to protect its monopoly. The reforms that we've proposed are a common sense step that everyone should be able to agree on. Right now, Congress has an opportunity to root out corruption in this system. But if we don't act before the current contract expires, we won't have another shot for years. Patients have waited long enough. Congress should pass the Securing the U.S. Organ Procurement and Transplantation Network Act and do it without delay. Thank you. Thank you all for being here and for your work. Thank you, Mr. Chairman.
Thank you, Senator Warren. We completely agree, and we have sensed the urgency here to act immediately. And as Dr. Lynch pointed out, delay means life and death here. So thank you very much for your comments. Once again, I want to thank all 5 of our witnesses. This has been an extremely important hearing and reinforces, I think, our desire to move quickly to open up competition, to provide transparency, to have accountability, all the above that we've talked about before, and to have a much sounder basis for finding out whether there's an equitable system here, not only a system that's efficient, getting the maximum number of transplants to save lives, but also to make sure it's done in an equitable and fair way. All that requires us to act on transparency, accountability, and competition, which we intend to do. So thank you all for your testimonies, and with that, the subcommittee hearing will be adjourned.